This video demonstrates how to diagnose Helicobacter pylori infection using image-enhanced endoscopy such as narrowband imaging (NBI) and LCI or link color imaging. A brief discussion on what is image-enhanced endoscopy and the techniques on magnification endoscopy will be included. The endoscopic findings of normal gastric mucosa and Helicobacter pylori positive gastric mucosa will be demonstrated. The desire to better recognize alimentary tract malignancies, which may be difficult to distinguish from nonspecific inflammation or trauma, prompted the development of new endoscopic technology capable of revealing cancer-specific images in the surface structure of the mucosa. It is within this context that the field of image-enhanced endoscopy was developed as a promising way to facilitate the endoscopic diagnosis of early neoplastic and precancerous lesions in the alimentary tract. Image-enhanced endoscopy is a real-time, on-demand optical image enhancement technology that enhances visualization of the vascular network and surface texture of mucosa, thereby assisting in tissue characterization, differentiation, and diagnosis. The propagation of light is determined by its wavelength. Red, having a long wavelength, diffuses widely and deeply, while blue, having shorter wavelength, diffuses in a smaller range. Hemoglobin is the primary chromophore of the gastrointestinal mucosa. The other components of the gastrointestinal tissue, such as the cell nuclei and the fiber, are colorless. Accordingly, the blue filter is designed to correspond to the peak absorption spectrum of hemoglobin to emphasize the image of capillary vessels on surface mucosa. The preparation of the patient for magnification endoscopy is the same as that for standard endoscopy. A soft black hood is essential for optimal magnifying endoscopy. Prior to examination, the hood is mounted on the tip of the endoscope to enable the endoscopist to consistently fix the mucosa at a distance of approximately 2 mm, at which maximal magnification of the endoscopic image can be obtained. When analyzing the magnified endoscopic findings, there are two distinctly different anatomical findings which we need to examine. Number 1, the subepithelial microvascular architecture, and number 2, the mucosal microsurface structure. We should analyze these findings independently. By white light alone, only the subepithelial microvascular architecture can be noted, but when we utilize image-enhanced endoscopy, both the subepithelial microvascular architecture and the mucosal microsurface structure can be visualized. This figure depicts a correlation between the microanatomy in the lower column and endoscopic images in the upper column. The microvascular pattern consists of subepithelial capillary, collecting venule, pathological microvessels, while the microsurface pattern consists of marginal crypt epithelium, crypt opening, and intervening part between the crypts. Basically, magnified endoscopic findings of normal gastric mucosa without any pathological change, such as Helicobacter pylori infection, are different depending upon the part of the stomach, that is, the gastric body or the antrum. The microvascular architecture of the normal gastric body shows a regular honeycomb-like subepithelial capillary network pattern which is brownish in color. The collecting venules appear stellate-shaped and are located deeper in the mucosa and are arranged at regular intervals and are called RAC. By magnification and image-enhanced endoscopy, the microsurface structure becomes evident. The microsurface pattern shows regular oval crypt openings, which are brownish in color, and oval marginal crypt epithelium. Both the microvascular architecture and the microsurface structure show a regular shape and arrangement. These are other images showing a normal gastric body mucosa comprising of small round pits surrounded by honeycomb-type subepithelial capillary network which are irregularly interspersed with collecting venules. Histological diagnosis of this pattern is a normal gastric fundi mucosa. In a study done by Anagnostopoulos et al., this pattern corresponded to normal gastric mucosa with a specificity of 100% and a sensitivity of 92.7%. RAC, or the regular arrangement of collecting venules, had 93.8% sensitivity and 96.2% specificity as an indicator of the normal stomach without H. pylori infection. On the other hand, the gastric antrum demonstrates distinctly different magnified endoscopic findings from those of the gastric body. The microvascular architecture of the antral mucosa depicts a coil-shaped subepithelial capillary network. The collecting venules are rarely visible as compared to the body because they are localized deeper within the lamina propria and the antrum. With regard to the microsurface structure, the antrum has larger circular pits in a regular reticular pattern with epithelial crests and narrow grooves. These are other images of the normal antral mucosa depicting a coil-shaped SECN with no collecting venules seen. In terms of the mucosal pattern, the gastric body was a conglomerate of regular small pits in which the dark areas were seen encircling the light areas, whereas the normal antrum pattern consisted of uniform, regular circular areas in which the light areas appeared to surround the dark areas. To appreciate these imaging patterns, one needs to focus on the light and the dark areas alternately, and the distinction between the body and the antral mucosa becomes more apparent. Let's move on to image-enhanced endoscopic findings of H. pylori positive gastric body and antral mucosa. To judge the H. pylori status by conventional endoscopy, the following findings should be checked. Number 1, existence of abnormal rugal hypertrophy in the gastric body. Number 2, abnormal diffuse redness. And lastly, abnormal whitish mucus. If more than one of these three features is observed, the stomach is diagnosed as having H. pylori positive active gastritis by conventional endoscopy. H. pylori associated gastritis of the gastric body visualized on image-enhanced endoscopy shows a honeycomb-like subepithelial capillary network with regular round pits but with loss of collecting venules. The loss of collecting venules is due to associated inflammation, and this pattern has a sensitivity of 100%, specificity of 92%, and a positive predictive value of 100% for H. pylori gastritis. Other findings include unclear or irregular subepithelial capillary network with enlarged white pits surrounded by erythema. The pits become rod-shaped, elongated, or ovoid, and irregular with prominent sulci. The detection of rod-shaped gastric pits indicate moderate H. pylori gastritis. This is an image of H. pylori infection of the body with blue arrow representing loss of subepithelial capillary network and black arrow identifying loss of collecting venules. These are other images of H. pylori associated gastritis of the gastric body. Both the microvascular and microsurface patterns show remarkable diffuse amendments compared with normal mucosa. The subepithelial capillary network pattern is dilated and the collecting venule is not visualized in the inflamed mucosa, while the martial crypt epithelium has a curved or oval shape which is different from normal morphology, and the crypt opening is not visualized as a brownish pit. In the gastric antrum, H. pylori associated gastritis is visualized as loss of subepithelial capillary network with irregular mucosal pattern as compared with the normal antrum. The blue arrows indicate loss of subepithelial capillary network, whereas the black arrows represent areas where a subepithelial capillary network is still present. Acute inflammation can also be seen as dilated pits with a thin or unclear epithelial layer and increased branching microvasculature. Uedo et al. Reported an interesting concept and new application of image-enhanced endoscopy with magnifying endoscopy for the diagnosis of gastric intestinal metaplasia. They indicated that a distinctive finding called the light blue crest or LBC was a good indicator of histological intestinal metaplasia, which is a risk factor for the development of differentiated type gastric cancer. Light blue crest was defined as a fine blue-white line on the crest of the epithelial surface or gyri as visualized by magnification endoscopy with image-enhanced endoscopy. This appearance is speculated to be caused by reflection of the short and narrow wavelength light at the surface of the slated tissue structure, that is, the brush border in the gastric intestinal metaplasia and the duodenum. Advanced H. pylori gastritis shows brownish patches with bluish margin and irregular border on a background of severe gastric atrophy as pointed by the arrow. These correspond to marked gastric atrophy and intestinal metaplasia. In summary, image-enhanced endoscopy has shown promising results in improving detection and characterization of gastrointestinal lesions. This allows better targeting of biopsies, improved prediction of histology with corresponding appropriate treatment, and better patient outcomes. On image-enhanced endoscopy, the normal gastric corpus and fundus have small round pits, subepithelial capillary networks in a honeycomb pattern, and stellate-shaped collecting venules arranged at irregular intervals in deeper mucosa. The normal gastric antrum has a reticular pattern of circular pits and coiled elongated subepithelial capillary networks. The collecting venules are situated too deep to be visible. H. pylori-associated gastritis of the gastric body shows loss of collecting venules, irregular subepithelial capillary network with irregular and enlarged white pits surrounded by erythema, while that of the antrum shows irregular or loss of subepithelial capillary networks with dilated pits. Lastly, the light blue crest observed in the gastric mucosa with image-enhanced endoscopy is a highly accurate sign for the diagnosis of gastric intestinal metaplasia.